Assalamu alaikum and welcome back to another episode of What's Up Doc. I'm your host, Dr. Al-Barwani, and I'm a board certified physician. My show, What's Up Doc, is a production of Muslim Network TV, the only Muslim focused network broadcasting in North America. You can watch us on Roku TV, Apple TV, Galaxy 19, and Fire TV. You can also go to our website at muslimnetwork.tv or our YouTube page at youtube.com/Muslim Network TV. According to the CDC, someone in the United States has a stroke every 40 seconds. That to me is a crazy statistic. World Stroke Day is observed on October 29th to raise awareness of the serious nature and high rates of stroke. In honor of that, we are talking to Dr. Amir today about strokes. Dr. Amir is a vascular neurologist and a neuroendovascular surgeon at Community Regional Medical Center in Fresno, California, where he serves as the Director of Neuroendovascular Services and the co-director of the stroke program. Dr. Khan is also an associate professor of neurology with UCSF Fresno. He has a clinical interest in treatment of stroke, brain aneurysms, and other disorders of the brain vasculature. Welcome, Dr. Khan. It's such a pleasure to have you.
Thank you, Aalia. I'm pleased to be here.
Absolutely. So, like I said, when I was preparing for this show today, I looked at the CDC and saw that statistic and was floored. 1 in 40, and someone's having a stroke every 40 seconds is a really high number. And we talked about the importance of World Stroke Day at the end of this month. And I'm sure you have to kind of talk about this every year or regularly, not just every year. So I would love to hear your comment about that statistic and what you do to raise awareness on World Stroke Day.
Yeah, certainly. And I have been talking about it, like you said, regularly throughout my career, especially around commemorative events like World Stroke Day and also American Stroke Month, which is in May. But yeah, it never ceases to shock me either to hear these statistics about what a big problem stroke is actually for our society. So, some other things that are quite relevant. We think there's about 800,000 strokes annually in the United States. It's the 5th leading cause of death in the United States. And worldwide, it's actually higher. It's about the 2nd leading cause of death in the world. It's a leading medical cause of disability. And per one estimate in the United States, it accounts for about $40 billion costs annually if you take into account costs of medical care and lost productivity from the effects of individuals who've suffered a stroke. So quite a big problem indeed.
Yeah, the effects are astounding and far-reaching, I'm sure, affecting, just like you said, not just the individual, but their healthcare system and support systems, et cetera. I'm sure the cascade and the effect of stroke is very far-reaching. So let's start by talking, or let's continue the discussion by talking about what a stroke actually is. So for people who may not be as familiar with symptoms, signs and symptoms, and what actually happens when someone has a stroke, I think that's a good way to kind of start this.
Yeah, so at its most basic, stroke is injury to the brain that happens because of interruption in the blood supply to the brain. And so I use the word interruption because there's 2 ways that can become interrupted. There can be the blockage of blood flow to the brain, and that's called ischemic stroke. And so that's actually the most common form of stroke that accounts for about 85% of stroke in the United States and maybe 90% worldwide. And when the blood flow has been blocked, that part of the brain can't sustain function without that and eventually die. So that's ischemic stroke. Then there's hemorrhagic stroke, which is an interruption of blood supply that causes bleeding. So in this case, you have explosive bleeding into the area in the brain, which of course damages that area of the brain. And hemorrhagic stroke is an even more potentially dangerous stroke in terms of mortality. We think that about half the people that get a hemorrhagic stroke ultimately don't survive it.
That's a pretty high number. So definitely a very serious thing to have happen to anybody. And as you mentioned, it results in injury to the brain. So what does that look like as far as symptoms that someone would experience when they're having a stroke?
Yeah, so this is another thing that can be confusing sometimes for patients, because unlike, let's say, heart attack, where the symptoms are fairly circumscribed, you can say 4 or 5 things that are going to account for the majority of the symptoms that most people who suffer heart attack will feel. For stroke, it's different because there can be a very wide consortium of different symptoms that can all nonetheless still be stroke. So because of that reason, the American Heart Association has put together an acronym called FAST that we think is a useful tool to promote. And what that stands for, F stands for face. So if you're having trouble with facial weakness or just asymmetry of your face, A stands for arm, so arm or hand weakness. S stands for speech, so trouble with producing speech or understanding speech. And then T stands for time, which is a reminder that you need to use your time wisely and quickly and call 911 and get to an emergency room. There's another one called B fast, which has become a little bit more in vogue recently because it adds 2 other useful reminders. So it's the typical fast that I talked about with the B in the beginning, B standing for balance, so trouble with your balance, and E standing for eyes, or trouble with your eyesight. But beyond that, beyond those tools, stroke can encompass a wide variety of other symptoms. Some people can have difficulty with loss of sensation of their limbs or some other part of their body. Some strokes are accompanied by severe headache, sometimes with nausea. Some strokes can be involved with just motor problems, meaning trouble with movement without these other symptoms. So, it's probably not really worth trying to remember all the different combinations of symptoms that can occur when someone's having a stroke. But I think the thing I try to tell patients and try to tell people when we talk about this topic is it's a sudden loss usually of some sort of ability that you normally should have, like walking or talking or writing or standing, things that are normal, and it happens suddenly. So contrary to other types of neurologic problems, the stroke tends to happen right away. So you're fine 1 minute, and the next minute you suddenly can't do something that you used to be able to do very easily.
Excellent. Thank you for that very thorough description. And I think that a few things that you said there that I really want to emphasize, and one is the mnemonic that you shared, be fast or fast. And that's really helpful for not just in one who's experiencing the stroke, but somebody who may be witnessing that as well. And so being able to quickly get the person who's suffering from the stroke help is very important as well. And then as far as the symptoms that you mentioned, even though there are so many other things, those are some of the most common ones that you shared with us. Is there a difference, because you did describe 2 different types of stroke, the hemorrhagic and ischemic? Do we see different patterns of symptoms depending on the kind you're having? And is time relevant for both? I would imagine yes, but I would like to share part of your.
Yeah, I mean, time is relevant. Well, time is relevant for probably one more than another. But actually, the interesting thing, I mean, it's a very good question because we actually don't know. So most people, people themselves, patients themselves, are not going to be able to tell, and even physicians can't tell. And so this actually has been studied with several studies where they looked at whether or not assessing physicians or medical staff could tell before the imaging was done of the brain, which is normally a CT scan or CAT scan, whether we could tell whether someone was having an ischemic stroke or a hemorrhagic stroke. And we're actually really bad at being able to tell that. So to answer your question, there's not really a reliable way to tell it. And so if we can't tell that, we can't expect that the patients are going to know that. So we have to then, from the patient side, from the response side, from the side of getting the patient to medical care as soon as possible, that has to be uniform because there's no way of knowing between the two. But probably to answer your question from a theoretical standpoint, ischemic stroke is the one where probably you presenting to the hospital or to the emergency room the quickest could potentially benefit you because there's a lot of treatment options that tend to work best in the early hours of ischemic stroke. But since we don't know, you just have to get to a hospital quickly if you think you're having a stroke.
Exactly. I like that advice because just like you said, because we don't know, and it's really interesting information that you shared from the study that even clinicians or physicians and people in the medical field don't know. And so it's really important to make sure that timeliness in getting care is taken. So you mentioned that imaging is going to be the way that we diagnose it for conclusively, but before we get to that, I've heard patients refer to something called, which we in the medical field call TIA or transient ischemic attacks, as light strokes. And so for those who may know it by that name, let's touch on that because while it's not technically a type of stroke, it is in that realm. And so I'd like us to define that for our audience as well.
Yeah, so I mean, that's correct. It stands for transient ischemic attack. It has the kind of unfortunate name of mini stroke, and so it's not really so my patients often think mini stroke meaning, you know, a small stroke, but it's not actually a small stroke. What it is, and the way I like to explain it is it's like an aborted stroke. So in again, the type of stroke that we're talking about here is the ischemic variety, so the blood vessel blockage stroke. So when you're having a TIA or transient ischemic attack, what's happening to you is that you're suffering the symptoms of one of the arteries in the brain becoming blocked. And so the symptoms that you're suffering are because the part of the brain that was receiving blood from that territory or from that artery is no longer functioning. However, for whatever reason, that spontaneously resolves. And so that's something that we know happens in other areas of medicine too, where a clot can form and then it can break itself up on its own. And so that can happen in the brain as well. So when you're having a transient ischemic attack, you're starting to have a stroke, but then miraculously or thankfully, the clot breaks itself up. And so then you improve back to normal on your own without any intervention. If you then go ahead and get imaging, particularly an MRI of the brain will usually look normal. And that's because we don't see any lasting injury to the brain, because the lasting injury that was going to happen didn't have a chance to happen because the artery opened up on its own. So that's why I like to really think of it more as an aborted stroke than a miniature stroke or a small stroke.
Very interesting. And so it is definitely miraculous that was aborted. People who have that should definitely count themselves lucky, but should they just move on with their lives? Actually before that, do patients who experience this, what are they usually describing? Because I know the symptoms can be different from what you just described as far as a stroke. And so will they experience symptoms that they also have to kind of get medical care as soon as possible to make sure? Because I mean, I guess it's hard to tell if it's going to abort or not, but if they do have symptoms that possibly do resolve, should they seek care, I guess?
So actually, the interesting thing is that they won't be able to tell. So just like we can't tell whether you're having a hemorrhagic or ischemic stroke, you also can't.
That makes it a little concerning too, right? I feel like that I would want to know if I was having an aborted stroke.
Right. Well, I mean, it's just a matter of luck, and so you don't know when this, because the way to think about it correctly is that a stroke is happening. So regardless of whether it ends up being a transient ischemic attack or whether it progresses to a full ischemic stroke, the initial presentation is the same. So you start at the same place. It's just that some people diverge to it becoming a transient ischemic attack, and some people then progress to ischemic stroke. But you're starting in the same place. So in the beginning, you have no way of knowing, is it going to go to TIA? Is it going to become an ischemic stroke? So your presentation is the same. Your symptoms are the same. And so then the second part of your question was, well, what should they do if they're lucky enough to their symptoms resolving on their own? You actually shouldn't just say, well, I don't know, that was a weird thing, and just move on with your life. You actually should still go to the emergency room. And the reason why is because when you've had a transient ischemic attack or a TIA or an aborted stroke, what starts to happen is that you're at high risk of that happening again. So that didn't happen. That wasn't a fluke, right? That didn't happen for no reason. That happened because there's some process going on in your body that's sending clots to one of the arteries in the brain. And usually when that happens, it didn't just send it once and that's it. That was just one of several. And the other ones that are coming, rather there could be other ones coming that could cause that event to happen again, or could cause an ischemic stroke in a more severe manner. So for all those reasons, if you're lucky enough to have a mini stroke or a transient ischemic attack, but then you feel better, you should still actually go to the emergency room. You should still be admitted to the hospital, because the workup that will happen in the hospital can actually help reduce the chance of you having a full ischemic stroke if we're able to identify the factors that are playing a role in you having had that transient ischemic attack.
Excellent advice. So speaking of the workup that goes into seeing what people's, what are the risk factors that we can mitigate, let's talk about risk factors. What puts different people at risk for getting a stroke?
Yeah, so there's a whole host of risk factors, and I'm sure you talk to your patients about. There's risk factors that you can control and can't control, and of course the ones that we can't control are age. So as we age, that the risk goes up, unfortunately. But there's a lot that you can control. And what's interesting is that I think in the journal Lancet a couple of years ago, they published an epidemiological paper that found that they attributed that 90% of stroke risk is actually potentially preventable with lifestyle changes, medication changes, and health changes. And so a lot of those things include the following. One is high blood pressure, which plays a role in a lot of other disease processes. I'm sure you've covered in the show with other guests, but it plays a big role with stroke as well. What we call dyslipidemia, or a cholesterol panel, which emphasizes the bad types of cholesterol, is also harmful. Obesity and diabetes play a role as well. And these things all play a role in the development of what's called atherosclerotic disease, which you may have talked about as well, which is an inflammatory process that happens with the lining of the arteries that can lead to a variety of problems across the body, including things like heart attack. But in today's topic, we're talking about its effect with stroke. There are some habits that are very harmful. Smoking in particular, cigarette smoking is a big contributor. Stimulant drug use, that would be things like amphetamines or cocaine. Alcohol intake in particular, if you're drinking regularly.
And when it comes to alcohol, a lot of my patients do wonder, is there a certain amount that's okay? Because there are some studies that show that it can be heart protective in certain instances. And so where are we drawing the line if we have that information when it comes to stroke?
Yeah, I mean, that's a good point, because the data is a little bit mixed in terms of alcohol with regards to health outcomes. And, I think a lot of that is very kind of muddy data right now, because, they don't specify what type of alcohol and the intake volume and things like that. We do know that there are some guidelines from the American Heart Association, American Stroke Association, that on average, if you're intaking more than 2 drinks per day of alcohol as a man and more than 1 for a woman, that tends to increase the risk of stroke, probably both ischemic and hemorrhagic stroke. But we don't know enough to say that, that's like a safe limit, or you can, as long as you're right below that limit, that there's no risk. There's probably a stepwise risk in terms of progression with that. But as you pointed out, there's other evidence that sometimes, in other arenas, alcohol might have some beneficial effects. So that's what we know so far.
Okay, thank you. So it sounds just like you said that there are some things that you can control and other things that you can't. The things that we can control, it's important to limit. And the things that we can't control, at least getting a checkup at your doctor's office and assessing your risk for that with your annual physical. If you do have dyslipidemia or high cholesterol or other medical conditions that can help, or not help, but can contribute to your risk. You mentioned atherosclerotic disease, and so that does include uncontrolled high blood pressure as well as diabetes. And so as far as risk, and so it's important to make sure that if you do have those other conditions, that you are making sure that that's under control and that you're under the care of a physician for those things as well.
Yeah, and what's been interesting is that stroke is increasingly becoming a younger person's disease. And I don't mean young as in, adolescent, but, I think most of us think about stroke as something that affects people that are, grandparents. But in reality, stroke is affecting younger and younger people. In fact, there was one study looking at the period of time between 2000 and 2010 that found a 44% increase in the incidence of stroke between people who are aged 25 to 44. So, those are people that we still consider young or early middle-aged.
Wow.
And that's because of, again, the rise of some of the factors you talked about, because as you realize, there's a rise in hypertension, diabetes, obesity, dyslipidemia within our population as a whole. I think the one thing that's been trending in the good direction is that smoking rates have been decreasing, but unfortunately everything else has been trending in the wrong direction. So that's resulted in stroke happening at younger and younger ages.
Yes, absolutely. Well, with the smoking, I mean, unfortunately, I feel like it's probably trending in that direction because more people are vaping now, but that's another discussion for another time. Yeah, we've created another problem. But,
yeah, don't know about vaping and stroke yet, but
yes,
so far no problem.
I'm sure it's coming. I bet. Well, we do have to take a quick break here. You're watching What's Up, Doc on Muslim Network TV, and we'll be back after this short break.
There are 16 million children struggling with hunger in America. That's 1 in 5 daughters, sons, neighbors, and classmates who don't know where their next meal is coming from. Yet billions of pounds of good food go to waste every year. It's time we do something about it. Feeding America is a nationwide network of food banks that helps provide meals to millions of kids and families in need. Visit feedingamerica.org to help them feed even more. Together, we can solve hunger. Together, we're feeding America.
When times get dark, we can't see the help that's all around us. Let 211 be your guiding light for help with food, healthcare, and other resources.
211, how can I help you?
Call 211 or visit 211.org. 211, get connected, get help.
Right here, baby. Look. Uma.
Something more than a birthday is happening here. Once you can see it, you can help. The sooner you recognize the signs of autism, the sooner you can make a lifetime of difference for your child. Start by answering a few simple questions at screenforautism.org.
Dad, they took over my bedroom. Come on, come on. Okay, Dad. 1, 2, 3. Dad! You saved me. Dad?
Are you okay?
I'm fine, dear.
Your hero needs you now, and AARP is here to help. Find the care guides you need at aarp.org/caregiving.
I am what hunger looks like in America. I am an 8-year-old girl who's not excited for the last day of school. Because this may be the last time I'll have lunch.
Till September.
I am a single father of 2 who works 3 part-time jobs, and that's still not enough to put food on the table. I was created by artificial intelligence from faces of the 1 in 8 Americans who struggle with hunger.
Feeding America, 200 food banks strong.
Assalamu alaikum, and welcome back to What's Up Doc. I'm your host, Dr. Al-Barwani. Today we're talking about all things stroke, and we're joined by Dr. Amir Khan. So before the break, Dr. Khan, we were talking about mini strokes or light strokes, and we were talking about just some of the things that people can do to help mitigate their risk for that. Now that we've kind of talked about those things, let's talk about confirming the diagnosis of a stroke, because when we met, as we said in the beginning of the show, it's really difficult to just do that based off of clinical assessment. And so there are some tools that we have at the hospital to confirm diagnosis for a stroke and then move on to treatment. So let's start with that, please.
Right. So when you get to the emergency room, one of the first tests that they're going to give you is something called a computer tomography test, or a CT scan, which used to be called a CAT scan. And so the CT scan is pretty much a quick way to decide, like we talked about before, is this a hemorrhagic or bleeding stroke, or is it an ischemic stroke? And basically the quick way that it tells you that is if there's blood there, then it's a hemorrhagic stroke. If there's not blood there, then it's likely an ischemic stroke. But that's just the first step. Now, let's say you have a hemorrhagic stroke, then you're gonna be admitted to the hospital, and you're gonna receive appropriate treatment for that, which may involve procedures to look and see what exactly is causing the bleeding, to make sure you don't have another bleeding event, to control the pressure in the brain that can develop from having had that bleeding event, and other types of supportive care. But on the other hand, if you're one of the people who's having an ischemic stroke, which is the majority of stroke, then you may also get a different type of CAT scan, which involves getting injection of dye through the intravenous line that the nurses would put in your wrist. And that dye would illuminate the arteries in the neck and in the brain. And the purpose of that is to see if one of the arteries, if one of the large arteries in the brain is blocked by a clot. So that's what we call large vessel occlusion. We call that LVO. And LVO happens in almost half of stroke cases. It depends on what studies you look at. Certainly, it's more prevalent in some places than others, but it happens in a large percentage of people with stroke. The reason why LVO, or large vessel occlusion is important is because there's a treatment now that's only been widely available worldwide, actually, since maybe the past 5 to 6 years, called thrombectomy, which is a process of which we can quickly emergently do a procedure where we go into the arteries in your body and then navigate further into the arteries in the brain and actually to the artery that's blocked. And then using a variety of potential techniques and equipment, we can remove that clot or reopen that artery to reestablish blood flow. And that has actually been single-handedly or shown to be the single-handedly most helpful thing that you can do to improve your chance of having a good recovery from stroke if you're having a large vessel occlusion. The important thing, though, we talked a little bit about time and how, T and FAST and B fast stands for time. That's important because you have to, in order to have the best chance of a good outcome, it's important that you get to the hospital as soon as possible. You have to kind of think of like someone who's being choked. So the longer that, or someone who's like choking on food, the longer that they're choking and you're not getting that stuck piece of food out, the lower the chance that they're actually going to have a good outcome. So it's the same way with your brain. If that artery is sitting there blocked for hours and hours and hours, and then you come to me and I can open it later, it might be too late, because just like the choking victim, if you go in there and you pull out the stuck piece of steak, like after 5 hours, well, it doesn't matter because they've probably already died. So that part of the brain tissue is going to not have a good outcome if it has to wait a long time. So by that example, it illustrates that you have to get treated soon. Now, even people that don't have large vessel occlusion, but get to the hospital early, may qualify for a different type of treatment called thrombolysis, or TPA is what we use the term for, TPA. And TPA is an intravenous clot busting medication. So it's a medication that's given through the vein, and it goes through the bloodstream, and it basically finds the clots, and it has properties to try to break up the clot and disperse the clot. Now, TPA by itself may not work in all stroke cases, and we know that people that are having a large vessel occlusion, TPA by itself only works to resolve that clot in the minority of cases. But both of those are powerful tools that we use to treat ischemic stroke. And the important point is that their efficacy, their ability to help, is highest earlier on, which is why it's important that you get to the hospital as soon as you can.
Excellent. So there's a variety of treatment from what I'm, just to summarize what you said, variety of treatment for each of the different kinds of stroke, but time is really important, just like with the example that you illustrated, because it's important to minimize damage to the brain tissue. And so those are, I think, the key points to remember when it comes to getting someone to the hospital. When it comes to,
I want to point out, like you said, it's a very time sensitive process. And the thing that can be tough with stroke is that, unlike heart attack or, breaking a leg or something, it's not often a painful situation. So we do run into a lot of people, without the pain stimulus forcing them to go and get care, kind of sitting on things. And one thing that's actually been very frustrating, and that I've seen repeatedly, I trained in Philadelphia and then Minnesota, and now I'm in California. No matter where you go, people have this tendency, a lot of people, where they want to take a nap when they're having a stroke. And I don't know where that comes from. I'm just surmising maybe it comes from when people have like a pinched nerve or something, and they figure, well, if I take a nap or if I'm feeling tired, but we see that quite often. And so I do.
Interesting. So to clarify, not that they think that it'll help, but, or is it because they think it'll help, or do they just feel really?
Well, I think they don't, number one, they don't realize that they're having a stroke, or they may not realize what a stroke fully is. Mm-hmm. And I think that they tend to associate it with, if I didn't sleep well, I might be a little bit foggy or a little forgetful. I don't know. It's odd, but then again, I've seen people who can't move part of their body who then take a nap, and then
very, very curious. And like you said,
curious, but it's common.
Of the country. Yeah,
I've seen it enough now to where it's something that people definitely believe for whatever reason. Again, not because I think, not that I think that they think that's a stroke treatment, but
Yeah.
just that's for whatever reason, their natural response to having a symptom of stroke. So just want to point out, you want to do the opposite of that. You want to go
get moving. You want to get moving.
You want to get moving. Yeah, you want to get moving.
Yeah.
Even if it seems painless, and I think maybe some of that's also people feel silly if they don't know what's wrong. That I think, especially this has come up with people who've had mini strokes or TIAs. They'll say, "Oh, but I'm going to go to the hospital. I'm fine," and they're going to say, "Well, what are you doing here? You're wasting our time," or something, right? But that's actually not.
But hopefully, they will have seen this episode and will have heard that there is a lot of benefit to going to the hospital, even
absolutely. Even though it seems counterintuitive, even if you feel normal at that point, you still want to go to the hospital.
Okay. So I love that we were able to clarify that and share some information. That's a new one for me. I'll have to pay attention. I mean, I'm not the first line when it comes to strokes by any means, but I'm going to start asking, did you feel like you needed to take a nap after you? So moving on from yeah, exactly. Moving on from treatment, I guess we can talk about after your first stroke, how can we prevent a second stroke? Because as we know, it's very common for patients after they survive their first stroke that their risk for a second stroke is very high. And so let's talk about secondary prevention. We did talk a little bit earlier about some of the prevention or things that an individual can mitigate or to control in terms of their risk. But perhaps when we're talking about secondary prevention, there may be some things that they can also have used for primary prevention as well.
Yeah. So as you said, once you've had a stroke or a transient ischemic attack, you are at higher risk of having a second event. Now, that risk can vary depending on your individual risk factors. And so one of the important things that happens when you're admitted to the hospital is you have an assessment of the risk factors that you have. So for instance, maybe you have something called carotid stenosis, which is a leading cause of stroke in the United States, which is where you have a plaque buildup in one of the arteries called the carotid artery that supplies blood to a large part of the brain. And if that's present, then you may be eligible for a type of intervention or surgery that can drastically reduce the chance of that happening again. So that's one example. Another example that we see quite often is something called atrial fibrillation, which is a heart rhythm problem, which actually accounts for, it was probably the second leading cause of ischemic stroke in the United States. And that's a situation where a rhythm problem actually can cause small microscopic clots to develop in one of the top chambers of the heart and then migrate to different parts of the body, including to the brain, and can cause stroke. And that's something else that can be diagnosed. So the important thing is to have an assessment done by either in the hospital or in the clinic. Sometimes that assessment period stretches out from the hospital to the clinic to cover both, to look for these specific things, these kind of smoking guns that could put you at risk for another event quickly. But beyond that, then there's changes you can make to your own lifestyle and to your own habits that can help reduce the chance of you having a stroke. And kind of the neat thing is that a lot of these things that you do not only will reduce your chance of having an ischemic or hemorrhagic stroke, but they can also double up in reducing your chance of having a heart attack and sometimes reduce your chance of developing things like cancer or dementia. So it's not just specific to stroke. So some of these things in terms of lifestyle factors can include quitting smoking. That's a big thing. If you're someone who is sedentary, meaning you don't get any kind of regular physical activity, then it's important that you change that you start to get some regular physical activity. The data for this is not super robust. So we don't have studies that show that people that started an exercise routine suddenly drop their stroke risk, but we do have a lot of secondary evidence that people that don't have as much physical activity can have that happen. In one study, they looked at people and they divided them into quartiles or groups of people that got the most or least physical activity during the day. And kind of in a progressive fashion, the people that had the most physical activity had the least risk of stroke and vice versa. So that's something that is important. Diet plays a very big role in all of these things that we talked about. So not just stroke, but also heart disease and cancer and dementia. There's a diet that you may have heard of that you probably, I'm sure, talk to your patients about called the Mediterranean diet. And the Mediterranean diet is a diet that has specific elements such as maximizing fish intake, maximizing fruit and vegetable intake, as well as things like nuts and legumes, minimizing the amount of intake of red meat, processed carbohydrates, which accounts for a lot of fast foods, minimizing alcohol intake and not smoking. The Mediterranean diet in its various forms, there's also offshoots that look for that are useful for treating things like high blood pressure. There's one called the DASH diet. There's one called the MIND diet, which specifically looks at dementia risk. But these different diets have been shown actually in a large body of various research studies to improve or reduce the chances of having stroke. One study actually, I think done in Europe, combined the Mediterranean diet in I think individuals who were older than 60. So they took these people, and what they did was they put them on the Mediterranean diet. Also, they didn't smoke and they got some regular activity. And there was a big reduction after about, I think, 5 to 10 years in the risk of recurrence, of the risk of stroke, whether it was first time or second time stroke, as well as also their incidence of cancer and heart disease, and also death in general, is what we call all-cause mortality. So those are important things that anyone can do without, the prescription from a doctor or even the need to see a doctor.
100%. We've done a few episodes where we talk about the importance of diet and how important it is to let food be your medicine. And that what you just described with those studies just speaks and adds to that. So absolutely, if you can get on a healthier lifestyle as far as eating, that will really help a lot with a lot of different things, just like you mentioned, not just with your stroke risk. Now, before we wrap up, I want us to—
Can I interject one more thing? I totally agree with that. The only thing that sometimes patients will say that sometimes is a little bit misleading is they'll say, well, I want to make lifestyle changes, but so I can get off of these medications. I hear that a lot. I don't like these medications. I want to be natural. And I think it's important to know that, we do want to emphasize those lifestyle changes, but the medications serve a purpose. And so things like statins, things like antithrombotics, such as aspirin, or blood thinners if you have atrial fibrillation, still very important. So you don't necessarily want to fall in the trap of thinking, I'm going to improve my lifestyle so that I don't need the medications. In that particular situation, once you've had a stroke, you want to combine the advantages of having all of those.
Thank you for adding that. Actually, that's a really important point, because with certain things like prediabetes, for example, or mild hypertension, there may be room for that. But when you've had a stroke, just as you mentioned, the damage has been done, and there was some underlying issues that led to that damage. And so it's really important to understand that there is the limitation that while changing your lifestyle does have a lot of improvement, it does have limitations, and combining it with medications in the direction of your physician is going to be really important in managing your care. So thank you for bringing that up. Before we wrap up, I want us to touch on the long-term effects of stroke, and with, in particular, we were talking in the break, how it can affect your risk for dementia. So let's touch on that before we end the show.
Sure. So, as you know, and I'm sure as your viewers know, dementia is an exploding problem in our society right now, especially as a society.
Actually, sorry to interrupt, but we actually did a whole episode. So if you haven't seen it, make sure you're checking out our website. Go ahead. I'm sorry.
There you go. You got to plug in.
Exactly.
But so we've all heard of Alzheimer's dementia, which is the commonest form. But what a lot of people don't realize is there's a form called vascular dementia, which is essentially dementia that can come from the effects of basically having had strokes, whether that's a stroke, a large stroke that left you disabled, or whether there were small strokes. One thing we haven't touched on, there are actually things called clinically silent stroke. So it's possible to have had a stroke and not realize you had a stroke. That does happen in some people. And so the danger there, it's good in that you're not disabled, but the danger there is that if you don't know that you've had a stroke, then you could be at risk of accumulating other strokes. And the cumulative effect of having had multiple strokes is that you are now at a higher risk of developing dementia as you age. So so absolutely, stroke risk reduction is not just for preventing the mortality risk from stroke or the chance of having a significant disability, but also preventing the onset of dementia as we age.
Excellent. Thank you so much, Dr. Khan. It's been such a pleasure having you and discussing the details of stroke in anticipation for World Stroke Day, and sharing with us some really important gems for not just somebody who may be experiencing it, but somebody who may be witnessing a stroke to be able to give help early and quickly. Thank you again for your time, and we appreciate you, and we wish you every success in your career.
Thank you for having me, and I appreciate it.
Thank you for joining us in another episode of What's Up, Doc. You can watch this and all of our other episodes on our website at muslimnetwork.tv and on our YouTube page at youtube.com/Muslim Network TV. I'm your host, Dr. Al-Barwani, and I'll see you next time on another episode of What's Up, Doc.